So some tracheostomy care. So all patients must have a trachea box at their bedside in case of emergency. This should be checked daily to ensure that it's full and has everything you need. And so here I have here with me are some tracheostomy boxes. So there's just a little blue box that should be at the patient's bedside. You open it up, it's full with lots of good things. There's a nice little checklist on the inside for you to have a little look at and make sure that it's full of what you need. Just another little point, so you also have one for laryngectomy patients as well, which is slightly different aids. So inner cannula, the inner cannula should be checked ideally every 2 to 4 hours to ensure that there's no blockage, it's nice and patent, to aid ventilation, speech. And if the patient is showing any signs of respiratory distress, this definitely should be checked immediately. You should ideally have some inner cannulas clean, ready on the side, good to go. When you swap them over, can be cleaned with a bit of sterile water. Cuff pressure should be checked at the start of each shift with a manometer and should not exceed 30 millimeters of mercury. So you would attach your manometer to the end of the cuff. The cuff also tells you the size of the tracheostomy. So for instance, this is a 7, 6, 8, it'll tell you on the side. So pop your manometer on, inflate your cuff to 30. If you notice any gurgling, or if the patient has a voice, this is a sign of a cuff leak. So if inflating the cuff to 30 doesn't work and you're having to excessively inflate the cuff, you need to consider if the tracheostomy is too small and ask the doctor to review. They may need it to be resized. Ensure dressings surrounding the trachea are changed when appropriate. The dressings surrounding the trachea should remain in situ for the first 24 hours and then changed every 12 hours subsequently or as needed. So suctioning. Patients with retained secretions should be checked at least 2 hourly and suctioned as necessary. Your patient might have a large secretion load and may need to be suctioned way more frequently than this. So suction past catheter through the window. When you've passed the catheter down, pull back before applying the suction. You don't want to damage the carina. So cleaning the catheter, pull the catheter back so that the black mark is behind the window and wash through with some saline water, which you'll have sterile water, which you'll have attached here. So when the patient has been removed from the ventilator, they will just have their trachea there. So what you need to do is some open suctioning. So sizing is in line with trachea size as seen in the cuff. So if you have a trachea that is a size 7, take away 2 times 2 will mean a catheter size of about 10. So they should pass easily down through the tracheostomy. Patients, as they kind of get better and stronger, they may have a really good strong cough, and so you need to make sure that not only are you deep suctioning, but also looking at the upper airways, so checking the patient's mouth for any secretions, so suctioning with a Yanker suction, and just maintaining good kind of regular mouth care as well. So speaking. So this is attempted when the patient's stable and has reducing levels of ventilatory support. So the patient should be able to cough and clear their secretions either by deep suction or Yanker, so should have less of a secretion load. So for trialling speech, what you should generally do, so if a patient, so their cuff will be inflated. So what you would do is you would do a suction, make sure that kind of you've removed most of those secretions, then you would deflate the cuff, so you can just do this with a syringe, so pulling back, deflating the cuff. As you are deflating the cuff, you should do a suction at the same time, so any of those secretions that have been sitting on top of the cuff, you're making sure that you're clearing them and reducing the risk of aspiration. Then allow the patient to settle, and they may cough initially. If they are coughing excessively, they may be struggling with the sheer amount of secretions. But if they're managing well and they're stable, so the whole time you're looking at their kind of respiratory rate, their saturations, heart rate. So once they're stable, you can, with a gloved hand, occlude the trachea and ask them to blow through their upper airways. So you're testing to see if there's any flow through the upper airways. It's popping your one hand in front of the mouth, one fingers over the occluded tracheostomy, assessing for airflow. You may ask the patient to practice some vowel sounds, so E's, A's, just to assess what their voice is like. If this is successful and you can hear a little bit of voice and they're kind of stable throughout, you can apply a speaking valve, so or a passe murmur valve. The cuff, of course, is deflated and popping on the speaking valve. So then the patient, this is a one-way valve, so the patient can breathe in, but as they breathe out, that valve closes and that airflow is pushed past up past their vocal cords, allowing them to create a voice. Initially their voice may be very kind of wet or kind of weak, so you're just assessing how can they manage. So initially they might only manage for a few minutes, but gradually you're trying to increase the time they spend at the speaking valve, and ideally placing it on when they have family members present or they're doing a FaceTime, just to allow them to speak and communicate with not only us but their family. The cuff must always be deflated when the speaking valve is in place. So also, if a person doesn't get on with the speaking valve, we can refer back to those fenestrated tubes. So it may be that the doctors have to take out the original trachea and replace it with a fenestrated trachea. So that's allowing those holes that allow that little bit of airflow past the vocal cords. So just to go back. So speaking, generally the first time it's done is by a physiotherapist or a speech and language therapist on the unit. Obviously as the patient kind of begins to get better and manage this better, then the nursing staff will be involved in deflating the cuff and popping on the speaking valve.